All right, so, all right, we're done with that guy. That guy, he didn't make it through. He had too much stuff. He was in the hospital for about 6 weeks, and nice gentleman, did not make it through this. Now we got a 37-year-old male noted for fever, new nail discoloration under his nails. Fever, new nail discoloration under his nails. We're in the cardiac section. Well, guess what? We went out of our car, and you know that thing, the stethoscope that we hang on our rearview mirror so we look cool to everybody who's driving by and goes, oh, they got a stethoscope, they're super cool. We took that off and we actually went in the room and we put it on the chest. Crazy times. Remember, all patients take medicine. All patients take medicine. And we put it on there and we hear a murmur. And it's a murmur, we actually had people that evaluated the physical exams on this patient when he was there before. And guess what? There was never a murmur, so this is a brand new murmur. And what do we see? You can see these things right here. Let's do some drawing. You can see right here. See this right here? My beautiful drawing on top of those. Those are splinter hemorrhages. Those are non-blanchable, red to black streaks that run longitudinally under the nail plate. They're a result of small amounts of blood leaking from damaged capillaries in the nail bed. This can be seen in what? Endocarditis, right? Endocarditis. So let's go through the clinical findings of endocarditis. Fever. Well, 90% are going to have fever. All right. Heart murmur. You can say new heart murmur, 85%. Petechia, less than 50%. Sublingual splinter hemorrhages, which is going to be under the nail, splinter hemorrhages, less than 50%. Ulcer nodes and Janeway lesions. Ulcer nodes are painful, raised red, purple bumps, and Janeway lesions less than 50%. Septic emboli, that's going to be noted on a CT scan, and this is somebody who has a stroke. That's why we do all these workups. You're looking for septic emboli, can be a cause of a stroke, less than 40%. Splenomegaly, less than 30%, get that. Retinal hemorrhage, those are those raw spots, less than 5% when you actually look in those eyes, do those crazy things. All right, look at this. Look at this imaging. Let's go right here. See that? You see that chunk of junk sitting there? Look on those valves. Let's look at that again. I'm going to go back and hit that again. Look at that. See that? Yeah, not good. Okay. So think about that is you have this big ball, we'll call it garbage, sitting here on those valves. In each heartbeat, that stuff, because it's not just one ball, it's like all these little microorganisms sitting there and all hanging out together in your heart valve. And then as that's going and they're sitting in that heart, moving back and forth, some of them break up and they go everywhere into the brain. So this is endocarditis. And this was a severe case. This patient did not live. All right, endocarditis pearls. Let's go through these. Best initial step, blood cultures. You want to get the blood culture. You want to find out what the organism is so you can get the killing shot, the best shot, and a sniper shot to kill the organism before it kills the patient. Most likely organism in intravenous drug use is going to be staph. Best empiric therapy, vancomycin and gentamicin. Empiric therapy. I know gentamicin scares people. Get assistance from your friendly neighborhood pharmacist. Hopefully you haven't pissed them off and they'll help you take care of this because it is a medication. What do you never want to give with gentamicin or megaloglycosides? What medication do you never want to get so you don't write a check and have to work for somebody for the rest of your life? What do you want to avoid? IV diuretics. Furosemide, right? Put those together, you lose the hairs in your ear and you can't hear anymore. So not only do they have endocarditis and they can't hear, and they probably have a relative who likes to sue people, and that would be a bad day. For endocarditis, for enterococcus, amoxicillin and gentamicin for about 6 weeks. For MSSA, oxacillin. Okay, so let's talk about this. You're going to say, now, usually start off with vancomycin. Once you know right away it's MSSA, you need to get on oxacillin, nafacillin. Why is this? Because if you have vancomycin on a patient with MSSA, their mortality doubles than if you switch them over to oxacillin. For serious MRSA infection, the preferred therapy is going to be nafacillin, oxacillin, or ceftriaxone. These agents are superior outcomes compared to vancomycin, including lower morbidity and mortality. Vancomycin is less effective against MSSA due to the slower bactericidal activity and poor tissue penetration. Very important. It's boards and real world. For strep verdans, ceftriaxone is the killer. All right, let's keep going back to this endocarditis pearls. Streptococcus. It's going to be about 60 to 80% of all endocarditis cases, verdans, Streptococcus verdans. If you see strep bovis, what are you going to do? Colonoscopy. Associated with GI malignancy, that's your board review question. Patient comes in with endocarditis, strep bovis noted on there, and they're going to be a whole bunch of choices. And one of them, you're like, why would I get a colonoscopy? The colonoscopy is because you have, once the patient is stable, you're not going to get the colonoscopy while they're unstable, because the GI is not going to do it anyways, but you're going to have to get them stable first, and it's going to be associated with increased risk of GI malignancy. If continued fevers, repeat cultures, 3 to 4 days, and continued treatment, you take weeks to sterilize a valve. Anticoagulation is relatively contraindicated for endocarditis, except in the setting of a metallic valve. All right, we'll talk about this. So what happened is you're getting these flecks, and we talk about these flecks that are coming from the heart. Remember that heart is sitting on that trampoline inside the valves, and then it pops off. You're getting these little smegmas, and the smegmas can get in your head. And if you have anticoagulation, you have an increased risk of bleed. So increased risk of a head bleed, which we want to avoid. So that becomes a very difficult situation, is when do you start and stop and start anticoagulation in the setting of endocarditis. Endocarditis pearls continued. Strongest indication for valve replacement. There it is, CHF. One of the valves has ruptured, and now the patient has CHF. To take out the infected valve, then there's no endocarditis. If you take out the valve, the infected valve, there's no endocarditis. Remember, Streptococcus bovis or Clostridium septicum, you have to think about the colon. If you have a prostatic valve, you can add rifampin. Rifampin penetrates the tissues. Major cause of culture-negative endocarditis, Coxiella and Bartonella, never grow in regular cultures. They have to be diagnosed with serology. Those things are going to change as we get better and better with PCR. PCR is going to be a game changer. More discussions on infective endocarditis, the diagnosis, blood cultures, Duke criteria, echo including TEE, so you can see the valves better. Endocarditis occurring within 2 months of prostatic valve placement. The valve was seated and a valve implantation was implanted. If there's no improvement on the first round of antibiotics, you need to replace the valve. So endocarditis within 2 months of prostatic valve placement, the valve was seated and a valve was implanted. When the valve was implanted, so now we need to replace and get no improvement first round of antibiotics, we'll have to replace the valve. I'm sure the CT surgeon will love you. You'll be best friends. I can tell you from personal experience, they will love you, especially if they use IV drugs in the first case and they go back to the IV drugs. That's their favorite patients. If it has greater than 2 months since the prostatic valve was placed, antibiotic treatment is usually generally sufficient. All right, we keep talking about the transthoracic versus TEE. The transthoracic echo has about a 75% sensitivity. The TEEs has 90% sensitivity. Why do we just not do TEEs on everybody? Well, first, it's a higher cost. You're an invasive, and you have a risk for injury, including esophageal perforation. The TEE is much better for paravalvular abscess. You need to get it. This is what we talk about is this embolization. You need to get CT imaging. Once you know for sure you have endocarditis, you're looking for embolization, looking for the brain, spine, and spleen. Brain, spine, and spleen. All right, let's talk about the modified Duke criteria. And this is what we're using to diagnose endocarditis. requires 2 majors or 1 major, 3 minors, or 5 minors. 2 majors, 1 major, plus 3 minors, or 5 minors. Major criteria: persistently positive blood cultures of organisms typical of endocarditis, endocardial involvement, new murmur, or positive echocardiogram. Oof, let's go back. All right, tell me when you're ready. All right, let's go through the modified Duke criteria. Requires 2 majors or 1 major, 3 minors, or 5 minors. What's our major criteria? Persistently positive blood cultures of organisms typical of endocarditis. We went through those. Endocardial involvement or murmur or positive echocardiogram. Now the minor criteria: predisposition, pre-existing condition, fever, embolic vascular phenomenon, nephritis, rheumatoid factors, positive blood culture changes not meeting major criteria. Positive blood cultures meet major criteria. Now let's talk about surgery for endocarditis. All right, if the patient's in acute heart failure, then you have surgery. They have a new heart block. So not only we have a valve, remember we showed the vegetative floating, it's kind of grown over to the side. It's hitting what? Our conduction system. Hitting the conduction system, the conduction system. If we have a paravalvular abscess, fungal infections, if it's fungal, it's going to be very hard. Remember, fungus is hard and slow to get rid of. If you have persistent fever or bacteremia, systemic, remember we saw that big vol, that vegetation there, and it's shooting and bouncing in the heart valve, in the atrium, and it's bouncing and shooting septic emboli everywhere. Vegetation 10 millimeters. They love this one on boards. That's a centimeter, right? Vegetation greater than 1 centimeter, 10 millimeters. Need a valve. Endoplex. So endocarditis prophylaxis. So patient has a prosthetic heart valve, including bioprosthetic or homeographic valve. Our history of endocarditis. Unrepaired congenital heart defects, including palliative shunts and adjuvant procedure. Conditions profile. So how could you get it? And listen, trying to get your if you never license. Would you want criteria prophylaxis? You really criteria are mainly going on. Let's go back. So let's think about protecting for endocarditis. Are also including biography need. For congenital heart defects that are unrepaired, need if repaired, just think about within 6 months to have it. It could be like fall back from your mind and say, all right, I got this, answer this correct. Conditions, according to this valve, there's stenosis or regurgitation, which is bicuspid valve prophylaxis. ASVS, HOCM does not require prophylaxis. 6 months after repair of the congenital heart disease. So let's go back real quick. Bicuspid valve, aortic septal defect, ventral septal defect, HOCM, hypertrophic cardiomyopathy, and 6 repair of defect, not prophylaxis. Procedure, we need to have prophylaxis. All procedures that involve manipulation, this is the one you hit the gum tissue, or the periapical reef, that's the or performing, or perforation of the oral mucosa. Remember, and they're going to see the body and get into your valves. Procedures of respiratory tract involving incision or biopsy of the respiratory mucosa. Tonsillectomy, adenoidectomy, with biopsy. GI procedures only in patients with an active GI infection. Worry about it. Procedure affect skin structure, muscle, skeletal disease. Surgery, place prosthetic valves or prosthetic intravascular, intercardiac. You're trying to avoid getting seated. Procedure not repairing. Dental we're getting injections, so anesthetic injections, lidocaine injections, dental radiographs, placement or removal of orthodontic appliances, braces, adjustment of the orthodontic appliances, placement of orthodontic braces. Respiratory, endotracheal intubation. So if you're intubating somebody, you may need to give them antibiotics because they have endocarditis. Bronchoscopy without biopsy, so you're not going in. Hopefully you're not hitting the structure or destroying the structure. Tympanostomy tube insertion. Procedures not requiring prophylaxis. Dental procedures. These are just routine dental work. Say they're doing a lidocaine injection or putting braces on, removing braces, putting in orthodontic appliances, adjustments, as long as we're not cutting the mucosal membrane. For respiratory is endotracheal intubation. You may have to give antibiotics because maybe you're intubating because they have pneumonia or they have an aspiration event before or during your intubation. Bronchoscopy without biopsy, do not require prophylaxis. And the cardiac is patients getting a TEE, so because we're looking transesophageal echo, you don't have to give them antibiotics for that. Gastrointestinal endoscopy with or without biopsy. Remember, when we had to, it's because we were working before, is when we had a known infection. This is where we're doing a biopsy. GU is where we have vaginal delivery, C-section, and unaffected tissue, urethrocatheterization, placing a Foley catheter, uretrodilation and therapeutic abortion, sterilization procedures, removal of or replacement of intrauterine devices does not require prophylaxis. So the procedures, just think about it, is when you cut into the mucosal layer, or you cut into the respiratory tract, or you cut into the GI tract, when there is infection in the GI tract is the one that's going to require prophylaxis. Well, so what is a prophylaxis? For dental respiratory tract, standard regimen is going to be augmentin 2 grams PO 30 to 60 minutes prior to procedure. Unable to take oral medications, give them ampicillin 2 grams IV or IM, or ceftriaxone or ceftriaxone 1 gram IV or IM. What if they're allergic to penicillin? Give clindamycin 600 milligrams PO, aceflozin 2 grams PO, or erythromycin or clarithromycin 500 milligrams PO. GI or GU procedures at the time of active infection. Remember, if they have active infection, standard regimen is going to be amoxicillin 2 grams PO or ampicillin 2 grams IV or IM. Penicillin allergy, give vancomycin 1 to 2 grams over 1 to 2 hours. Okay, what's culture negative endocarditis? So we suspect endocarditis, but we have no growth in 3 sets of blood cultures greater than 5 days. Culture negative. What can this be? But we have fatigue, low-grade fever, splenic infarcts. Fungus can do it. Fungus are harder to come up. Now, as PCR gets better and used more, we're going to have better understanding and better diagnostic technology. Hopefully, we'll have less culture negative. Fastidious bacteria. This is Coxiella burtonelli. This is droplet exposure from infected cattle, livestock. Very hard to grow. Where you can have Q fever, which is pneumonia, flu-like symptoms, and hepatitis. Bartonella. Treponema whippi. Okay, let's talk about Whipple's disease. What is this? Let's diverge over. We're going from cardiac, from our endocarditis, we're going to Whipple's disease. We have weight loss, abdominal pain, diarrhea, joint pain, arthritis, personality changes, and memory loss. Is a gram-positive bacilli that's positive on the periodic acid shift stain and acid fast stain negative. Remember this, foamy macrophages on biopsy. Now, if you get a PCR, it will come up on a PCR. Initial phase is ceftriaxone 2 grams daily or penicillin G 2 million units every 4 hours. Usual duration for initial phase is 2 weeks, followed by maintenance phase with trimethoprim sulfametazole twice daily for 12 months. So it takes a long time to treat. Meropenem can also be used in initial phase of patients with a penicillin allergy. That's T. Whippley. That's Whipple's disease.